Okay, well, thank you. Thank you for the introduction. Uh, I'm Rex Paulino. I'm over here at UT Houston, and today I'll be, for this brief hour, I'll be talking about goals of care, really from a busy clinician standpoint. And as y'all will figure out and soon find out if you haven't yet, we are busy. We are busy a lot, and the complexity of the cases that we are involved day in and day out, it's so complicated. And I think it's very important for us to understand and to realize how do we make it better for us so we actually don't burn out. And this might be like a good segue from Priya's talk, because first I'll be talking about how burnout and how really it negatively impacts our ability to perform our job. But I won't spend too much time there because I want to be able to talk about what are the common barriers that we will encounter from a patient standpoint and also from a clinician standpoint. And then finally, we'll talk about, tips and strategies and how can we make it better for us overall so that we can move on with our lives and do our jobs effectively. Now, I don't know if y'all are fans, but I am a huge Star Wars nut. Well, I love Disney in general, but I'm a huge Star Wars fan. So we'll use a Star Wars twist into this talk. So if y'all haven't watched any of the trilogies or the older movies, especially the first three ones, then you guys are like what, 2, 3 decades behind. But I'll try to give some references to make this talk interesting. So that one right there, that's Anakin in the Battle of Mustafar. That's when he turned into morphed into Darth Vader. But we'll first talk about burnout. So when I gave this talk last year, I just recently updated my slide deck to show the latest set of data from the 2024 Medscape report. And what's interesting is that if you look the graph, I mean the line at the top, that represents burnout, and then the line at the bottom represents folks who are depressed. And mind you, I think they surveyed 25 different specialties, not specifically including hospice and palliative medicine. But what's interesting is that from 2020 to 2023, you see that there's like this spike going up, and I think we can all account that to the pandemic. But what's good to see is that things are starting to slowly trickle down. So while there's still a lot of us who are either burnt out or depressed, numbers are coming down. So that's always a good thing to see. Um, this is the spread of the different specialties that they included in this survey. Emergency medicine is still leading the charge. And the numbers are fairly similar from last year. And again, they didn't include our specialty here, but we'll talk more about that later. But just to give you guys an idea, these were the numbers from last year. So in terms of the top three specialties who were most burnt out from the previous survey, and that includes emergency medicine, peds, and internal medicine, the numbers have gone down, especially for peds and IM. We've gone down a good amount from looking from like 60 to 50%. So that's good. So either we're doing something right or something is changing from a system-wide standpoint, but that's always a welcome change. Looking at what really contributes mostly to burnout, it's really all about the bureaucratic tasks, and we don't have too many hours. There's only 24 hours in a day, and we can't push that even further. So there's only 24 hours in a day, but the amount of responsibilities that we have to do, it's there or it can go up. So we need to be mindful of our bandwidth, of our ability to manage our time wisely, and really looking at what are the workplace measures that would help the most with burnout. I would love to see this, every single time increase compensation because that helps us a lot. But what's interesting here is from last year's survey, um, making the work schedule more flexible was number two. What's interesting to see is adding more support staff jumped to number two. And I don't know what was the situation in y'all's institutions, but at least here for us, we're sort of borrowing our social workers and chaplains from the hospital. There's not enough people who can help us. So yes, I agree and I echo this wholeheartedly. We need more people. We need more support staff to complete our teams. Um, this is also interesting because from last year's survey, 65% of the respondents said that burnout has negatively affected their personal relationships, and it's only gone up to 86%. This is, I guess, this is a little bit, sad to see that around 50% of the respondents felt like their employers didn't really seem to recognize that they're being burnt out. But then you also have to remember this is just coming from one side of the story. Uh, it's promising to hear that at least talking from this article, they mentioned that the healthcare executives are recognizing the importance of burnout and how it's a physician well-being is an incredible quality indicator. It's a good metric to look at favorable outcomes and also to recognize staff turnover. So hopefully they're really taking steps to make it better for all of us. About a third of the time, the respondents said that they wanted to talk about burnout. A third said they didn't, and the other third didn't really have an opinion. And looking at the coping mechanisms, and this is a really interesting slide. Looking at the coping mechanisms that physicians use for burnout, a good 50% of them said exercise, sleeping, talking with friends and family, spending time alone, the top part. And really, if you look at all of these things, these are all from an individual level, like an individual perspective, which if you think about it, all of the issues with burnout starts from a systems perspective. But the solution that we're seeing is all individualized. So now you see that there's like a huge disconnect. The system-wide issue, they expect that us individually as clinicians need to know how to regulate ourselves so that we can mitigate burnout. So that's the huge gap that we're facing. And I want you to think about that moving forward. Now, I'm not going to spend too much time talking about the definition of burnout. We had, a good amount of discussion about this from the last talk, but really it just translates to exhaustion, depersonalization, and it leads to inefficiencies and high turnover. Now, because of all the different shows and Disney's a money-making company, they keep producing all of these either movies or series. And like, for example, there's been a lot of talk about people who are getting burnt out about all of these shows that are coming out left and right. But for me, I'm a fan, so I like it, but it's not uncommon that you hear people say, oh, there's just like way too much. But talking about burnout, I wanted to bring in a new concept to everyone, and that specifically relates to burn-in. So, burn-in is a phenomenon that is more recognized in the tech industry. So, I don't know if y'all have uh, if you're like me and you like to do a lot of research. So when I was trying to look for a new TV, I did a lot of research trying to figure out what's going to be a good one that serves that fulfills my wants and needs. So really, if you're looking at like all the different types of TVs, you have your LEDs and then your Neo QLEDs are like the newer technology versus the OLEDs, which O stands for organic LED TVs. Over the past 10, 20 years, there's been a huge demand for OLED TVs, and that's because the product that they release is just like really good, and people love that technology. The problem with that is the burn-in phenomenon. And if you look at this right side of the screen, that's burn-in. So burn-in, what happens is that if you turn on an OLED television, leave it on the same channel, let it run for hours and days, and then you switch to a different channel, you have all of these burn-in marks, and they stay there, and these are permanent. Um, what happens with OLED TV is that these are individual pixels and they're organic. So once you burn out a pixel, it stays like that and it leaves a mark. So much so that if you switch a channel, you can see the mark there. And the way that you fix this is either you send it back and it'll be a costly repair, or you throw away the TV. So if you use that analogy, looking at clinicians and how and why burnout, which could eventually turn into burn, is such an important concept to think about, is that when people are burnt in, um, you don't even recognize that you're burnt out. And because of that, it turns into this nasty spiral. And ultimately, you have people leaving leaving the specialty, leaving the field, quitting their jobs, or, at the very extreme end, some people even commit suicide. So this is the thing that we need to be able to prevent: is how do we recognize this and how do we act on it? Um, this article that was published, I believe, 2017 in JPSM, looking at the palliative care clinician burnout in our organizations and what do we need to do. And just like what I mentioned earlier, it's very problematic, especially for our field, and we need to be able to mitigate burnout. But the problem is they're expecting us from an individual level to fix the issue, which is all from a systematic standpoint, like a systematic level. So just like, going back to that analogy with the burn-in, what the technology that these newer televisions are using is what they call pixel shift. And I saw this one day when I was like watching on my TV. I saw that there was like on one side of the television, there was just like all white pixels. Like it was like a one or two rows of pixels that were just all white. And I sort of freaked out because I was like, this is a brand new TV. What's happening here? Is this defective? So it turns out this is the pixel shift. So that's the protective mechanism that they use, wherein they have the array of pixels and they shift them up, down, left, and right every couple of minutes so that you prevent burn-in. So just imagine if you have something like that, wherein you can maybe create a tandem system wherein you have a buddy system, you have someone else watching out for you, trying to make sure that you're not getting burnt out. So you have like a backup in case you are not recognizing that. That's going to be helpful. Or if you can get buy-in from your leadership so that you can send surveys to everyone, anonymous surveys to check in if anyone's burnt out. And then all of these data gets sent to, let's say, your division director, and they can see that, okay, well, this person is actually getting burnt out. Let me intervene. So we need to have buy-in from people up top to see, for us to be able to work effectively, mitigate burnout so that we can continue doing on our jobs. Um, so with that being said, let's move on to the second part of the talk, which is talking about what are the different patient-related and clinician-related barriers to discussing goals of care. Now, this was an article that was published in JAMA Internal Medicine, I believe back in 2015, looking at a different barriers to goals of care discussions. And really what they did here was they surveyed internal medicine residents, faculty, and also nurses across 13 different hospitals in Canada. And I believe they were able to get over 1,200 respondents. And just to bring everyone's attention to the bottom of the table there, what's interesting is that around one half to two-thirds of the respondents said that no, we never received any formal training in goals of care discussions. And I want you to keep that in mind because for this next graph, and I just wanted to explain this a little bit better, the researchers were looking at what's the importance of the barriers to goals of care discussions as perceived by clinicians. So basically, when they surveyed the residents, the faculty physicians, and also the nurses, they were all saying, a good majority of them were saying that it's the family or the patient's family, it's the patient or the patient's family who are the biggest barriers to goals of care discussions. Whereas looking at that lower box right there, ask the clinician, yes, you also have barriers to goals of care discussions, but it's much lower compared to the patient and their families as barriers, which is interesting because, like I said, one half to two-thirds of these folks said we've never had any training, but that was their perception. It's the fault of the patient and their families that they're not understanding all of our discussions. And this is another spread, another figure that shows looking at, and I'll highlight all of different people so it's much easier to follow. Looking at physicians, residents, advanced practice nurses, social workers, and other allied healthcare professionals. Looking at these people, how acceptable is it for them to initiate discussions, exchange information, be a decision coach, or make a final decision? And the way that they created this is that if you look here on the right-hand side, the white dots are the residents who are respondents. The blue dots are the faculty or staff physicians. The orange dots are the nurses. And then what you can see is that at least for all of these folks, they said, yes, it's most acceptable for staff physicians to initiate discussions, to do the information exchange, make a final decision, and be a decision coach. But as you go down the list, how acceptable is it for residents to do this? Yes, it's still in the same, around the same area. But as you go down looking at nurses, how acceptable is it for the advanced practice nurses or nurses or social workers to do all of these things? You start to see that there's a good amount of spread there. What's interesting is that the residents that are represented by the white dots and the staff physicians are leaning more towards the left. They're shifted towards the left, meaning they don't feel as strongly that these people, that these folks right here should be doing most of these responsibilities. But the nurses were saying, yes, we can do it. I think the takeaway that I have here is that consistently, everyone, all of these folks should be able to initiate discussions and be a decision coach. But I think for the the responsibilities, the tasks that have a higher weight to it, meaning information exchange and making a final decision, physicians need to take a higher like a higher set of responsibility in like accomplishing these tasks. At least that's how I interpret it. This was another article that came out in Sage, Palliative Medicine in 2011, looking at what are the perceived barriers and facilitators from a clinician standpoint and from a patient standpoint. And what are these when it refers to goals of care discussions? And they divided the factors into three different ones. So you have your structural factors, process factors, meaning how should the communication take place? And then you have your other process factors, meaning which topics should be discussed. So looking at the patient level, they were saying, well, barriers include the medical condition. If there's like a language barrier, like a cultural gap, these are potentially barriers. And what makes it better, what facilitates all of these discussions is, at least from their study, they were saying, oh, older adults tend to have, like, as you age, that is a facilitator in having these discussions. And I think the way that they made sense of this is because as you age, sometimes you have a better acceptance of everything that's happening. You've lived your life and you're more willing and ready to move forward with these discussions. Whereas for the clinicians, the barriers include, well, the lack of availability. We just don't have the time, right? And there's prognostic uncertainty, especially if you don't have all the information. Those are huge barriers as opposed to the facilitators, wherein if you have a long-standing relationship with the patient, you know them, and especially for the primary care physicians, since they've developed a lot of relationship, like a huge relationship with their patients, then they are in the best position to facilitate these discussions. Whereas looking at the process factors, how should these talks take place? Barriers for the patients is that they just don't feel that they're ready. They're ambivalent to talk about prognosis. And there's so much uncertainty that that's a huge barrier for them. And this can also translate to physicians, wherein, or clinicians who just didn't have enough experience. They don't have that much exposure in having these discussions. It becomes a huge barrier for them. So that's why getting the training is essential. And that's what you're doing here for your 1 year of fellowship. And being able to being open and honest with your patients is it's a great facilitator of these discussions. And looking at what are the topics that should be discussed. Again, spirituality and religion is a huge barrier, especially for patients and also for clinicians who don't know exactly what to do and how to respond, especially when the patient starts to say, well, you know, God will take care of me, he will heal me. Sometimes you're just stumped and you don't know how to proceed, you don't know how to respond to that. So that's why I feel like making sure that you have your interdisciplinary team with you during a family meeting, during a discussion is helpful because they can save you. They can help navigate all of these complexities, and it allows you to be able to approach it from a more medical standpoint also. And then lastly, I want to talk about the strategies that we can use to ultimately make it easier or better for us to have a better flow. And I think it really starts with introduction. Every time I have learners with me and we go into a family meeting, one of the questions I always ask is, if you're coming in and you introduce yourself, how do you do that? Because if you walk into the room and you say, "Oh, I'm palliative care. The doctors wanted me to come and see you to help with symptom management or to help with treating your pain, or you have bad nausea, so we're here to help you with that." That's a much easier conversation as opposed to you walking in there to talk about goals of care. And I wanted to, I guess, like open it up to the group. If you are about to walk into a room and say, I'm palliative care, and the consult was for goals of care discussions, what do you tell your patients? Like, how do you introduce yourself? I don't think I could see the chat. Oh, there's the chat. I'm just seeing this now, Ben. Where's the fifth largest medical specialty? Yes, that was
Yeah,
like a long running joke from like the specialties and how they always for some reason they always left out palliative medicine.
yeah, that Medscape thing that you showed didn't have hospice and palliative on it.
Right, yeah. Um, but yeah, so I'm looking at Ashna. You asked them first if they know what palliative care even is. Yeah, absolutely. And I think that leads to my next slide is I'm just curious, what do y'all tell them? If you're seeing them for the first time, do you introduce yourself as palliative care, palliative medicine, supportive care, supportive medicine, or do you have like some other specialty that you tell them? I'm just curious to see what's you know, what we have. Tell 'em- Yeah, so that's good. So Ashna is saying that essentially what what this means is you define what specialty is, right? You try to do that best way that you can to help them understand why you're actually there seeing them. It might be a little bit different if you're seeing them in clinic, because I think for me, a good half of the time when I see my patients in clinic, they don't know why they're coming in to see me. So my first visit always involves me telling them what I do and probably why they were sent over to my clinic so that I can see them. So I'm seeing we introduce ourselves as advocates for family and patient. I love that. That's great. Because that's essentially what we are, is that we are excellent patient advocates. We try to bridge that gap. We are the ones who are trying to make sense of things if they don't, right? And that's why we are, for the most part, like called into many of these discussions. Let's see. Okay, so around 80% use palliative care, so that's good, and then palliative medicine. Now, let me show you guys, well, that one and also this. Um, so looking at the definition of supportive care from MASC, so that's Multinational Association of Supportive Care in Cancer, their definition of supportive care is it's the specialty that deals with the prevention and management of the adverse effects of cancer and its associated treatments across the continuum of the care, from the point of diagnosis through the treatment to post-treatment care. So that's their definition of supportive care. Now, I like using this definition, which is CAPC's definition of palliative care. So it's a specialized medical care for patients living with serious illness, and it focuses on the relief of symptoms to ultimately improve your patient and their family's quality of life. We provide an extra layer of support, and it's appropriate at any stage of the illness and can be provided with curative treatment. So it's a mouthful, right? But if you have that definition nailed to the T, then whenever you introduce yourselves and you at least give that spiel, then hopefully it sticks, hopefully it lands, and your patients will have a better sense of why you're seeing them. This article is an interesting one. It was published by our friends over at MD Anderson, and they were looking at what is the association between a name change. So they changed their name, and I can't remember exactly like when they did this, and I can ask Dr. Nguyen about that later on. But so whenever they changed their name from palliative medicine to supportive care, they were looking at what was the rate of patient referrals that they received from their colleagues. Like, did it improve with them changing their name from palliative care to supportive care? And looking at the results, so the top part right here is looking at what is the time interval from either from hospital registration or from the point of diagnosis of advanced cancer, and from that point on, how soon did they receive a supportive care consult? And what you can see is that their numbers improved significantly. So from 13 months, it went down to like a 9 month wait, and from around like 7 months to about 2 months. I mean, around 5 months. So the time that they had to wait from the point of either registration, hospital registration, or point of diagnosis to an actual consult with them being able, from them being seen in clinic, went down whenever they changed their name from palliative care to supportive care. It didn't really translate well for the over on the inpatient side. And at least the way that they made sense of this was that, well, they were saying it was first and foremost hard to interpret the significant delay in the time of consultation. However, they were suspecting that it was because of the overall increase in the like the volume of the patients who were more severely ill, and they were saying maybe that's the reason why. the numbers went up instead of going down. But at least that was how they interpreted their data. This is a Kaplan-Meier curve looking at the overall survival from the first palliative care consultation until time of death. And at the midpoint there, there's a good amount of spread, I'd say maybe 2 months, 2 months difference, 2, 3 months from the point that they uh changed their name from palliative care to supportive care, and then from the patient being first getting through registration or point of diagnosis until they were seen. And then how does that translate to mortality? So at least they were saying that, especially for the outpatient center, there's a bigger spread there. And they were saying that the name change that they did was more beneficial for patients who are being seen in clinic because they were able to provide supportive care services at a much earlier date. So that at least translated to a better survival rate. Yeah, I'm looking at Melissa's message. Yeah, I completely agree. It's just like from one side of is what they were seeing. Yep. Yeah, definitely agree. Now, I don't think this will change my practice. I mean, because at the end of the day, by the time I see them, I still have to explain to them um, what the specialty is and what we do and what I do for a living and how can I help out. So I think at the end of the day, as long as they're able to like make it to your door and you're able to explain to them what you're doing, I think that's going to be that's going to be helpful if you explain to them what is it that you do for a living and what you can help out with. Establishing rapport, I don't have to, emphasize this enough because we need to do that. And this helps us to build our relationship with our patients so that they can really trust us. It helps foster trust and openness. It allows us to have a more comprehensive plan. And it really just shows your patients that you care if you're able to establish rapport like effectively calling us puppies and kittens. Yeah, I mean, like, unfortunately, we don't have pet therapy in our hospital. That would be neat if we have that. We can walk around with like puppies and kittens, and that would, be another great selling point. Yeah, it's so rare that patients don't follow up. Yes, I completely agree. That's like a good first 5, 10 minutes of the visit is I have to explain to them why they ended up in my clinic. Uh, but I think the outcomes are all, for the most part, like good. But yes, you're gonna have to explain to them why they're seeing you. Um, if they're seeing you for symptom management, I feel like it sticks better because they have something to cling on. If the let's say the oncologist tells them that, oh, let me send you to one of our colleagues who can help out with managing your pain, that lands better. But if it's for, goals of care, it's kind of hard to do that introduction because first of all, the person who's putting in the referral needs to do a really good job explaining why they're sending them over to come and see you. And do your patients even remember that? Um, and depending on like how they deliver that, there can already be some distrust, so they just may not even show up. So what we actually do on the over on the inpatient side is because we have both inpatient and outpatient palliative care is that whenever we get consults to establish palliative care, I never say no to these consults because it helps me explain to them what we do so that I feel like the turnout of patients showing up to clinic is much better if I meet them for the first time and I tell them, oh, this is what I do and this is how can I help you out. Now, this is, I think I shared the volume. But this was when Obi-Wan felt that this whole planet Alderaan you know got blown up because the Death Star just like blew it with the laser.
Disturbance, of course. Is it millions of voices suddenly cried out in terror, suddenly silenced? If something terrible has happened.
Yeah, so I just wanted to show that because for the next slide, it's uh it's really tapping into your senses. So I use this a lot whenever I meet my patients when it comes to talking about goals, is I try to read the room a lot. I try to listen, right? And this is what I tell people is that the best the best communicators are the skilled listeners. So there's so much that you can accomplish just by listening to your patient. You observe with your eyes, you sniff out any potential issues, and you're trying to be tasteful with your words, and you provide the human touch, the comfort. So just remember like your five senses and try to utilize these tools whenever you're going into a family meeting. And I think that helps distinguish us as a subspecialty compared to like the others. If y'all aren't following Sunichi Nakagawa in Twitter or X, I highly recommend that you guys give him a follow. If you follow like Dr. Bruera, he spits out like so many palliative pearls in Twitter. Dr. Nakagawa, so Sunichi, he throws in a lot of family meeting and goal to care pearls on Twitter. So it'll be it'll be worth following him. But the way that he dissects a family meeting, and I use this also this format, is there's like three big ones. The first part is really um, you know, breaking the bad news or sharing information, sharing serious information. So you set the stage and know this talk is not meant to replace the communication workshops that you guys will do in your own institutions. I am sure that your program leadership will have something in place for that, but it's really just having a framework and remembering this while using all the tools that you guys will learn throughout your training and throughout your workshops. Having that in mind, it sets the stage so that you can hopefully have a more successful meeting. So it always starts off with sharing the information. And one thing that I always tell people is that try to remember the 50-50 rule. If you're talking more than 50% of the time, then you're talking way too much. You want to be able to get your patient and their families to talk more, because without them talking, you are not going to be able to learn from them what's important to them. And after that, it segues into what's important to you. So this is where your remap mnemonic comes into play, and you'll learn more of that during your workshops. But that's how you connect from sharing information and then talking about what's important to you. And then after that, you always present them the options. Now, and this is something that I completely agree 100%. I try to avoid asking my patients what they want. And let me talk about that a little bit more. It's not because we don't want to hear from them, but the problem with the want question is that if you ask a patient, well, like for example, if we were to talk about code status, the discussion always goes, and it's usually saved at the very end, uh, when your heart stops beating, and you stop breathing. And we talk about this to all of our patients, but I just wanted to ask you this question: if your heart stops beating and you stop breathing, do you want us to do absolutely everything to bring you back uh, to life? And if you phrase it that way, then the only logical answer is yes. Anything other than that does not really make sense. So you need to set yourself up for success. Otherwise, you're just shooting yourself in the foot. So instead of asking people, what do you want? Typically, what I do And hopefully what you guys will also learn as you go through your training is that it's very important that you talk about their goals first, talk about prognosis, and based on what they told you is what's important to them, then make your recommendation. Make your recommendation that, well, after hearing everything that you just told me, it sounds like being able to go home and spend time with your family, watch the sunset from your backyard is something that's very important to you. Then what I recommend is something called do not resuscitate. Then you go ahead and give your recommendation. Because the problem with asking people what they want is that, let's say you ask them, oh, do you want to undergo resuscitation? And if they tell you, yes, I want it, and you're like, oh crap, I wanted them to say, no, I don't want it, then now it becomes an uphill battle for you to be able to convince them that, oh, well, really, you should have picked the other one. And then if you do that, then there's really no shared decision making. You're not aligning with your patient. So that defeats the entire purpose. And it makes it much more difficult for you to be able to have a good outcome. So usually what I recommend is just like always always go through what's important to them. Always talk about their goals and based on that give a recommendation. And I think if you do that for the most part, you'll be okay with your family discussions. Now, this is another concept that I like to talk about is really what's the difference between your big orchestrated goals of care discussions versus your mini goals of care discussions? Because, and you'll probably see this more and more, you don't have to have a full-on sit down, let's have a goals of care discussion, talking about what's important to you every single time, because every single encounter, if you just learn to listen and know how to frame it back to them, you're doing many goals of care discussions. And you can always start with meeting them for the very first time. It's like the first visit, you introduce yourself, and then you say, oh, I'm from this specialty. Uh, and your doctors wanted me to come and talk to you to see how I can best provide support to you and your family. And you try to get to know them. And the more that you ask questions, the more that they talk, the more that that you'll figure out what's actually important to them. And then hearing all of these things, and this is something that that we like to use, it's called APR. So that's acknowledge, pivot, and return. You acknowledge what they told you, and you pivot, and you say, well, it sounds like X, Y, and Z are, you know, all these things are really important to you. And then they'll tell you for the most part, yes, because they just told you that's important to them. And that's you affirming what they just told you. And right then and there, you already had a goals of care discussion. Now, this is important because if you're doing all the heavy lifting, you will get burnt out, which brings us all the way back to the very first part of this discussion. So what I actually like doing is I like to play the talk show host. I like to pass along the mic to all the other members of the team. So it all starts off with the pre-meeting and just delegating and telling people, okay, who's going to lead the meeting? Who's going to give the updates? And then if the oncologist is here, then let's have the oncologist talk about the cancer. And then based on how this discussion flows, and maybe I'll talk about, you know, comfort measures if they're ready to talk about that, or if not, then let's try to flush out some more goals. But if you do that, you essentially lessen your workload. And what's left is you're just delegating and you are navigating through the discussion. So the amount of effort that you put in gets smaller. Then you let other people try and talk about their piece and try to lead the discussion, and you just pass along the microphone. If you do it this way, then you conserve your energy better. You'll have a better vantage point so you can see what's happening in the room. You can read the room better. You can see that the patient's daughter who's like sitting in the corner is starting to cry, and you can attune to that better. You can hear other people better because it's hard to talk and think about what you will say next and think about what's going to be the next medical intervention that's going to be offered, it's hard to do all of these things in real time. So if you are looking at everything from a third person point of view and you allow other people to do some of the talking, it allows you to do a much better job to lead the meeting. And I think as you progress with your training, in the beginning, you need to first learn how to do the meeting, and then eventually learn how to lead the discussion. And ultimately, as you are just about ready to graduate, learn how to delegate so that you can conserve your energy just in time for graduation. So it's always good to be prepared. It's always good to plan ahead. Just like I said, it's important to delegate tasks so you don't get burnt out. Try to conserve your energy, but also remain flexible so that if you see that this discussion is not going to be able to move forward in a fruitful manner, then it's always okay to call time out and say, you know what, we've talked about a lot of things. How about we meet again? We'll reconvene in 48 hours, 72 hours, or whatever. That allows you to maintain your sanity, but also recognizing that you have your own bandwidth and they also have their own bandwidth, and you need to stay within these dimensions. Rebecca Sador from UCSF, she developed Prepare for Your Care. This is a really useful tool that saves a lot of time for you to be able to focus on other things. It's translated in a lot of languages, and you just like give the link to your patient and tell them, hey, have you ever thought about advanced directives? Have you ever thought about appointing anyone to be your medical power of attorney? Here's a neat website. Why don't you explore that? And then we can talk about it the next time. And this is very helpful, especially for patients that you see in clinic, because that saves you that time having to drill down many of these things, and it allows you to talk about other things. And just because I'm in Houston and we got hit with, Hurricane Beryl 2 weeks ago, I think, it's always very good to prepare. You don't want to be this guy on the right who didn't prepare well enough, didn't have a generator, and had to rely on his lightsabers to have some light. I didn't have any power for a week, and all of these things didn't last for more than 24 hours. So it was very it was very tough. It was painful, but I was able to move through. Moving on, this is so Rachel Bernanke. She's incredible Jerry Powell physician over at Harvard. So she created this toolkit, if you will, on the different communication strategies for serious illness communication, and best practices that she's specifically tailored to primary physicians. And it essentially just echoes everything that we've discussed so far, that early goals of care discussions and all of these discussions ultimately improve care, and that there are really no potential harms, and the likelihood that having these discussions increases depression, anxiety, and hopelessness is actually very low. There's like no evidence to support that. The only cost is that it increases clinician time, but if you are really efficient with your workflow, then you'll have a way to figure out how to navigate through these discussions and be able to survive the end of the day and still not be so burnt out. We talked about the different barriers. And I think the big thing here is for the systems barriers, the challenge that we have is we are living in a society where in life-sustaining treatment, life-sustaining care, survival is the default. So that's why our job is really complicated, but it's up to us to be able to bridge that gap so that we can meet our patients in the middle and still hopefully be able to recognize what's important to them. And yes, training, and a lot of practice is what we need to do to get better with this. So she's identified several triggers that would be useful to look at and help us decide when is it a good time to have a goals of care discussion or to have a family meeting. And there's a good amount of information here. But I think if you skim through everything, the important thing to recognize here is that if there's a change in their situation, if there's a change in their status, either for good or for bad, then that might be a good time to talk about what's important to them. And I think if you do this more routinely, it allows you to further develop your rapport and your relationship with your patients because they're seeing you multiple times and they get to trust you more. And there's always room for feedback. What I will tell fellows is that when you're finally up and running and you're leading your meetings, do not be afraid to ask for feedback from your faculty. That's why they're there. They're supposed to help you navigate through all of these things. So do not be afraid to ask for feedback because that's the only way that you can get better. But and also at the same time, what I always tell people is that, and this is from Radical Candor, uh, always praise publicly, but provide feedback privately. And then that's eventually your journey from, from starting out as learners to become master clinicians and master communicators. So in summary, communication, it's the cornerstone of our healthcare. Words matter, they matter so much. And then ultimately practice makes perfect. These are my references, and thank you. Y'all have any questions? Oh, that's me, by the way. I like to cosplay. So I'm a member of the 501st Legion. So we do a lot of Star Wars like cosplay. So that's me. I'm cosplayer.
Um, how many lightsabers do you have? Was that really all of your lightsabers that you lined up?
Yeah.
A lot of
I think I have
lightsabers.
12.
Okay.
Yeah, but with that, it still wasn't enough. Like the battery only lasts for about like an hour.
Um, well, thank you, Rex. It's a great talk and really nice to conceptualize, right, goals of care, work smarter, not harder,
Right.
have a better view for the team approach. I guess the one question that I had personally, it looks like everyone else didn't have any questions, but I was wondering when you're doing that delegation and you're asking people to come in and give their own piece. I guess the thing that scares me the most is taking the conversation out of my hands, and I'm not sure, right? Hey, speech therapy, go tell them about the results of the swallowing study, and then speech goes in and says, well, aspirating all consistencies, so they need a peg, right? Like, how do you help coach that?
Yeah, it's a really good question. So, and that's the value of the pre-meeting is that I will specifically tell people, okay, we're going to delegate some of the tasks, and you get to talk about this, you get to talk about this, and the overall, I guess the overall agenda is that we want to make sure that they are aware of all of these things, but we'll try and stay away and navigate away from, let's say, like a peg. And just, I think being mindful about it and making everyone aware that this is really what I want to accomplish. Um, I think that works for the most part. And if I see that they're sort of like lost in the weeds and they're starting to ramble about all these things, and that's the time that you, as the one who's leading the meeting, should just jump in. And that's where you need to learn how is it, what's a good way to interrupt someone to jump into that part of the discussion and reel everyone back into this one other direction that you were hoping to achieve. So that takes skill and a lot of practice too. You'll meet like different people who it's just like so hard to interrupt them. So you just try to set the expectation, I guess is what I'm saying.
Could I add
Is
something?
how I always like do the pre-meeting.
That no, I don't have anything to add, but that's like the trick. The vital talk trick is, can I add something?
Right.
Is a really good way of interrupting, right? There's one more question in the chat.
Ah, that's the $1 million question. How do you fix this? To be honest with you, um, like the solutions that I have are still on the individual level, but just making sure that having people serve as your backup so that in case you are not recognizing that you are getting burnt out, someone can step in and say, "Hey, are you okay? That was, that was a difficult conversation. That, you need to have a buddy system, but you also need buy-in from that. So if you know like leadership from your division or your department, and they implement that, okay, well, we're gonna have like a buddy system, or we'll have like an anonymous reporting system that you can say that, oh, I'm concerned about this person. I think that's like the first step, but it still takes a lot of work from like an individual level. So unless we make like a systems change and that's like implemented all throughout all throughout the institution, then it's going to be a work. It's going to be a lot of work.
Thank you again, Rex. I'm going to stop the recording.